Stewart here, man.
Forward. Is this the clicker?
There's no beverages in the room.
Okay.
Yes.
Pretend you're not drinking beverages.
It's milk. It's Vermont. How can you yell at
So
me?
if I just forward here, do I forward?
Kale.
I think you can point it at the computer.
It's local.
Yeah. Page down.
Look, what we do that, John?
Oh, look at those
If you
The
can.
insurance executive says it takes.
Yeah.
All right, well, they're figuring out the clicker. I wonder, is the thing in the side? Is the thing in the side of the laptop that makes the clicker work?
The page down.
The phrase that comes out of the clicker?
Oh, I hate
There,
those
okay.
ones over there. I'm sorry.
All right.
Okay. All right. Thank you,
Okay, don't
Spencer.
worry, folks, we're in charge of your healthcare system.
Don't panic.
This is real confidence.
Yes. So welcome to another meeting of the Green Mountain Care Board. Today we have just one announcement before we get underway, I believe, unless George tells me there's anything else. The one announcement is that we did appoint our advisory committee. Yesterday we notified 41 people that they had been chosen for our advisory committee. I believe there's a copy of the press release around here somewhere, and that includes a list of those who've been appointed to that committee, and that includes the 41, include Don George, who's here to talk with us today. Because of the tremendous response we got to our solicitation for volunteers for our advisory committee from a couple of arenas, one being healthcare providers and the other folks who were either providers of or interested in mental health and substance abuse. We are also announcing that we're establishing technical advisory groups in those two areas. So we'll have a provider technical advisory group. Everyone who applied to be on the general advisory committee who was a healthcare provider has been invited to be on the provider technical advisory group. And they have until March 15th to let us know if they'd like to accept that invitation. We're also accepting self-nominations from other folks who would like to be on the provider technical advisory group. In addition, we are forming the mental health and substance abuse technical advisory group, and likewise we'll be accepting applications for that until March 15th. In terms of the general advisory committee, first of all, the first meeting of that group will be on March 15th, right? Is it 15th? 14th, sorry, we're not going to get that. Now that we made a mistake, we're not going to get that out of our heads. March 14th at 10 a.m. At Vermont College. The advisory committee is a really nice, broad spectrum of people who have specific expertise and interest in the healthcare system, but mostly of people who don't have a specific interest or expertise, just ordinary citizens and healthcare providers of all types who wanted to be involved in our work. So we're pleased to announce that, and we'll be distributing this press release this afternoon to the media. Any other announcements or comments from my colleagues before we get rolling with? Oh, we have to do our minutes.
Move that we approve the minutes of Thursday, February 9th, 2012.
Second.
Any discussion? All those in favor?
Aye.
Okay, minutes are approved, and now we'll move on to today's agenda, which is a presentation from folks from Blue Cross Blue Shield of Vermont, who are going to give us an overview similar to what MVP gave us at our last meeting. Talk to us about their company, who they cover and how in Vermont. And I think we'll have lots of questions for you, but we'll be particularly interested in your thoughts about insurer rate review, which we're going to have a role in starting now, and how we can best implement our charge to bring to the insurance rate review process considerations of things like affordability and quality. And also your thoughts on payment reform. I know you've been deeply involved in some of the payment reform efforts to date, and would be interested in your perspectives on payment reform generally. So thank you, and I'll leave it to you, Don, to introduce everybody.
Well, thank you. We'll be sure to cover all those things. Good afternoon, Anya. Good afternoon to each of the members of the Green Mountain Care Board. Thanks to others who have taken time out of a nice afternoon to join us here today. I'm going to be joined by two colleagues. I think you've had the chance to meet them. Kevin Goddard from Blue Cross, right at my right, and then Catherine Hamilton, who are both vice presidents with Blue Cross Blue Shield. This afternoon, I'm going to start off with our vision for the future, which really goes back to late 2008, 2009. Kevin is going to talk about our business and what we think makes us unique, what we think separates us from the industry that I sometimes refer to as that industry that we're associated with but not part of. And then Catherine's going to talk about our members, what we have done to and the great lengths we've gone to build into the culture of our organization, our core value and mission that we call always put the member experience first. And she's going to talk about that today and in 2014. My closing thoughts are going to be very brief, and then we'd really like to have the opportunity for a dialogue and to respond to any other questions that you would have. We know you gave us from Georgia, we received some advanced questions. We've woven them in, if not to the slides, then to the talking points. And so if we don't cover each of those by the end, then we'd hope that you'd ask us a question about it. Kevin, are you going to be able to?
Yes.
All right, I think I see. There we go. Back in late 2008 and 2009, we used a management transition at Blue Cross that resulted in my becoming the CEO as a way for management and the board members to consider Blue Cross Blue Shield's position in the Vermont healthcare system, what we were doing on behalf of our customers, what successes we were having, and what flat spots and shortcomings we were having in delivering on our vision at that time. My sense at the time was that the entire health insurance industry was at a crossroads. Our strategic plan became known as Crossroads. From our perspective, each of the participants in the health insurance industry needed to choose the road they were going to go down. Was it going to be one that was going to be more historically tied to the mission, vision, and value proposition of the industry as it had been known for the past 20 years? Or would it be a new one that would be tied to a future value proposition? It was our sense that we needed to go down a different path than what we had been on before. And what we offered was three simple strategic assumptions that are on the board behind you. Three very simple, what I call to be sort of the fundamental truths of healthcare reform. One was that, and this was before the Shao report, this was before Act 48, this is in early 2009. We were operating under the presumption that government would have an increased and permanent role in healthcare. From our perspective, given the evolution of some of the European healthcare systems, this was a desirable thing in terms of ultimately furthering the vision we were going to have for Blue Cross Blue Shield of Vermont. The second thing was that, well, ACA was in its infancy and being debated in Washington, and where healthcare reform and healthcare in general was a compelling national issue. The reality is healthcare is delivered locally. And all healthcare reforms, by evidence of Act 48 and your having been formed into a board to oversee all of Act 48 implementation, healthcare is delivered locally, and all healthcare reforms are going to have to be enacted locally by committed stakeholders that are willing to work together. So given that government was going to have an increased and permanent role, and given that healthcare is delivered locally and those reforms will be enacted locally, from our perspective, there would be significant value to a local, independent, not-for-profit, single-state-focused health plan like Blue Cross Blue Shield of Vermont that was willing to go down sort of the road less traveled by way of that crossroad, was willing to take its strategic plan for the future and fashion it around the healthcare reforms that were going to be going on in the state of Vermont. That from our perspective, as an organization, we'd become a partner to government and a catalyst to those healthcare reforms. And by doing that, we could best serve our customers and we could best serve the people of the state of Vermont. Now I've taken my glasses off for who knows what button I'll hit. There you go. So we recrafted our vision and our mission. Our vision is one that we think, although it was put together in 2009 and 2010, we think that it is one that aligns well with health policy makers and with people like yourself tasked with implementing healthcare reforms. It is quite simply for a transformed healthcare system in Vermont in which every Vermonter has healthcare coverage and receives timely, effective, affordable care. We know that this is a vision that we cannot accomplish on our own. What we like about this vision, what I like about this vision, is it does compel us to work with other stakeholders in what we would view as a public-private partnership of stakeholders coming together, working with government, and subordinating their own self-interest and advocating for the whole solution. The whole solution being that every Vermonter have coverage and this to be timely, effective, and yes, affordable health care. The second thing that we did was we changed our mission and we simplified it to really have three component parts. The first is that we are committed to the health of all Vermonters. We take seriously our need to finance health care for those people who have serious illnesses and be there for them at a time at what might be the most challenging and stressful time of their lives. By the same token, we also have tools and programs and incentives for those people that are well to stay well, those people that are ill to get better, and those people who have chronic conditions to live with those conditions and work with the physicians as best that they can and as affordably as they can. The second thing was what we call responsible cost management. As an organization, we know that we don't see patients, but we are involved in care delivery. We work with physicians and we work with patients, and we want to do that in a responsible way that does not get in between patients and their physicians. And so we call that responsible cost management. The heart and soul of what we feel our mission is all about, the driving force for every Blue Cross employee when they come to work in the morning, is what we call our commitment to outstanding member experiences. We've backed this up with a training program at Blue Cross called We Care. CARE being an acronym for creating authentic, respectful experiences. Every employee in the company has taken 10 hours of training in terms of how we as an organization produce outstanding member experiences. Generally, the belief of all Blue Cross employees is service can be provided one employee at a time, but experiences for our members are created by the entire company. The second thing, after a new vision and armed with a new vision and a new mission, what we've done is crafted what we see is the future role for Blue Cross Blue Shield of Vermont. And when I speak to people across the state of Vermont in our community meetings and to our customers and to health policymakers, I always explain this in terms of my career at Blue Cross. When I left the Medical Center Hospital of Vermont in 1993 to go to work for Blue Cross Blue Shield of Vermont, I was most assuredly going to work for a health insurance company that had a relatively simple value proposition. We processed claims and we did it quickly and accurately. We answered the phone and we answered questions quickly. We took risk on behalf of our employer groups. And over the next 15 years, at the behest of regulators and our customers, we evolved from being a health insurance company to be a health plan in which our function and value changed significantly. Our payment models changed significantly. Our service models and certainly our care management programs grew and were augmented during that entire time to a suite of programs that are known today as Blue Health Solutions. That was really an evolution over a 15-year period. We see what we are today as a health plan changing significantly, and not changing over an evolution of the next 2 decades, but changing rather as a transformation and probably relatively rapidly over the next 3 to 5 years. We think our function and value will change again. The payment models and our views on the payment reforms that are going on in the state of Vermont will change. Our service models will become more proactive, focused on wellness and focused on outreach and guiding people through a delivery system. And our care management programs will change. We'll become far more integrated with local reform efforts into what we've referred to and are referred to in the blueprint as care extenders. Some of our care management programs will likely go away entirely as we reform care models and as physicians become the locus of providing care. We've taken this and have extended it somewhat and have added 4 dimensions that we're focusing on would be the heart of our future value proposition to a reformed healthcare system in the state of Vermont. And if I start at the upper left-hand corner to what we call care management integration and transition. From our perspective over the last 20 years, health plans that evolved from health insurance companies have created care management programs that have resulted from our all operating within a care delivery system that is less than optimally integrated and organized. So in many ways, health plans create care delivery systems for patients, one member in one disease state at a time. If we transform the healthcare delivery system, which is our goal and the goal that you have and is the goal of Act 48 and healthcare reform in Vermont, then ergo from that, many of the care management programs that were created by health plans as stopgaps to a less than optimally designed delivery system no longer need to be in place, at least in their present form. And so what we're doing is committed to transitioning and integrating those programs, transitioning some entirely back to providers and integrating some with providers in a far different way than they are today. Largely speaking, we don't see Blue Cross Blue Shield of Vermont 5-7 years from now being in the business of care management in the way that we are today. The second thing is what we'd call, and I'm going down to the green part of the chart, support for delivery system transformation. We actually have a lot of experience through our involvement in the Vermont Health Plan in doing all kinds of risk and payment reform models with providers. So even today we have global capitation models with Fletcher Allen and Vermont Managed Care. We see that expanding. We see our being in the area of risk management, taking risk and sharing risk with providers in different payment models and global capitation models, prospective forms of reimbursement in a very large way, than even more so than we are today. We know we need to back that up with strong data and analytics and aligned reimbursements and aligning those reimbursements with the delivery system changes that we all want to bring about. The third dimension is what we call consumer engagement, health, and wellness. And today what we're doing is dramatically expanding and enlarging our wellness and condition management programs that we do with employers and individuals. From our perspective, this goes well beyond the wellness of the 1980s and 1990s in which we thought about pedometers and healthy eating cookbooks. This is once again a circumstance in which we're giving incentives for people who are well to stay well. For those people that are ill, how they're going to manage their illness and get better. And most importantly, for the 70% of our costs that is driven by people with one or more chronic conditions, we are finding ways to provide incentives and programs through our employers and to individuals for them to be able to be very knowledgeable about their chronic conditions and work with physicians on those chronic conditions in a way that is very enabling and totally engaged for both the physician and for the individual. The final dimension we have of Vermont's Health and Wellness Company is not one that we're really developing for the future or furthering today. It's one that exists, and it's what we refer to as worldwide care. We want for all of us to be aware that as Vermont leads the country with very aggressive and very far-reaching healthcare reforms, that we are not an island, that Vermonters travel every day. We're part of a global economy in which people travel across the country and indeed around the world. Our proudest moments are those in which we're able to help people when they're traveling away from Vermont with the care that they need. Well, we're an independent Vermont company. Our association with 38 independent other Blue Cross Blue Shield plans across the country ensures that Vermonters, when they travel, will have access to care whenever and wherever they need it across the United States and in over 200 countries across the world. So our archives are flush with very good examples of circumstances in which one of our members is traveling in Costa Rica and they run out during an extended stay in that country of a prescription drug that they really need in order, it could be life-threatening if they don't have it. And in those circumstances, we're obligated to get a Spanish-speaking customer service rep on the phone talking to the pharmacy to assure payment so that member gets their prescription drug. And we need to be available when we have a member of ours visiting her son in the Peace Corps in South Africa, and she becomes ill and is in Nairobi Hospital. And we're contacted by Nairobi Hospital, one, because they want to be assured of payment, and two, because they want to let us know that they cannot care for her. So we need to be there to get her airlifted to Paris, where she can receive the treatment that she needs, arrange for the payment through our global worldwide system, and then make sure that she gets back home and that all of her care gets hooked up with her Vermont care deliverers. So that is something we do today, something actually we're quite proud of.
I want to stop you before you go to the next slide. First of all, I think Al's probably happy to hear what you just said because he's going to Costa Rica next week. I just hope you have Blue Cross coverage.
How did you know?
I didn't.
That's pretty good intelligence work.
Yeah.
My wife doesn't even know.
So you've talked about sort of being different from your colleagues around the country. On these fronts on which, where you've taken your new mission to a more concrete level, what distinguishes you, when you talk with your colleagues around the country, what are they doing in terms of care management, payment methodologies, et cetera? Are you really in a league by yourself, or are there others in the insurance industry who are doing this kind of stuff?
I think that the thing that separates us is that I'm still seeing the industry. I'm indeed seeing Blue Cross Blue Shield plans still trying to lead care delivery transformation through innovative health plan programs. And I think that ultimately where we want to get is that what we want to be supportive of is new clinical pathways, new clinical models that are on the floors of our hospitals and in our physicians' offices that may not need what we're referring to as the innovations of health plans, health plan-based care management programs today. I remain very open and have had a number of healthcare providers in Vermont suggest that things that we're going to show a couple slides to you of our end-of-life care program, our Better Beginnings care program, where we did not have the scale in our small communities in order to be able to have fully functioning care models and care delivery models. I'm very open to having those at a centralized level, but only if it's acknowledged that it fits in to the new care systems for the future. So we don't necessarily see the care management, the clinical innovations taking place at a health plan level. It's providers who will lead that.
And in contrast, insurance companies around the country generally are still pursuing that model of
Are still
changing
feeling like that there are those innovations that can be had at a health plan level that can lead that effort. And I think the thing that distinguishes it, Anya, is in who leads this. And I think that many health plans still think that health plans will lead this in partnership, with providers. I think that we really need to enable, support healthcare providers to lead this on their own. They're the ones that are seeing the patients. They're the ones that are closest to the care.
One other question on wellness. How do you do that? I mean, do you hire vendors? Do you have people internally who do it? And how do you either build it based on evidence or gather evidence as you're implementing those programs to tell you what works and what doesn't?
What we start, and right now we're doing this with employers of 100 or more. We're developing an individual-based program we hope to have for 2013. Now this begins with, it's really feet on the street. We do have some vendors involved, but what we do is we have staff who will go in and will do a wellness health management assessment of an employer that is relatively in-depth. We'll sit down with them and provide both observations and information to suggest here's where their opportunities are, here's where some of the programs where they could take advantage of some of the programs that we have. Catherine's going to talk a little bit about a product we've developed that we call an accountable care product. Distinct from an accountable care organization, this requires that employers, in order to be in the program, take advantage of certain aspects of our wellness program. And it begins with what we call a leadership-led health and wellness commitment within the organization. So I've talked with many of our customer CEOs about the need for them to build this into their cultures, the need for them to lead by example, and for them to ultimately, they're going to get more than just managing the medical component to their premium. They end up with more productive and engaged workforces. That's ultimately the goal. We want to help them to accomplish their business objectives, not just their healthcare management objectives. So Catherine will talk a little bit more when we get to it. We have a slide on what we call the accountable care product, which really encompasses the wellness program.
Maybe you'll get to this too, but we certainly want the providers to lead this innovation effort too about a new delivery system design. But being a provider, we also know that they'll expect to have the right change in value and compensation follow how they do this hard work. So what do you think about, how do you look at Blue Cross Blue Shield in terms of reforming how our payment system rewards providers?
Well, our philosophy of that really developed a few years ago with some pilots we did before the blueprint went into place. We did them in Springfield. We did one in St. Johnsbury as well too. And at the time, this is part of what I see as the crossroads we've gone down. Generally, the way that a health plan goes about doing an incentive-based program for physicians is they take a lot of HEDIS measures and they ask the physicians to perform above certain benchmarks for those HEDIS measures. And in the event that they do, then they receive a bonus at the end of the year. Now, there's a lot of reasons why the physicians might not, in very small panels particularly, perform to those HEDIS measures. From our perspective, the lion's share of the reason why we shouldn't necessarily expect a different outcome when we're still paying them the same and asking them to perform to a higher level of expectation on those HEDIS measures is that we're not giving them the time and the resources to redesign the system in which they see the patients that ultimately they'll develop better outcomes for, that will develop higher HEDIS measures. So we worked with a group of physicians in Springfield in which we talked with them about if you were going to be seeing your patients most optimally, and it was diabetics, what would that look like? Instead of a 15-minute office visit, what would it look like? There would be an advanced planning for these patients. You'd have a registry and you'd know when they were coming. And we identified with them and we committed to a contract a series of things that represented really a mini different model for them seeing diabetics. And then what we did was we identified what would be the advanced stream of money you'd need to receive from Blue Cross Blue Shield to fund you in order to be able to do these things. And we worked with them to identify, the cost accounting of what would exactly that be. And then we provided them with that advanced stream of payments so they could afford to see the patients, they could afford to have advanced planning. This was in Springfield where they were already considered to be an advanced service area for diabetics, and they did better over a 2-3 year period. Now we eventually rolled the St. Johnsbury program we had into the Blueprint for Health. But my general feeling is that we need to carefully identify what providers need in order to be able to develop a different system. And then we need to provide the financial support prospectively to fund that system that we're convinced will give us different results. It shouldn't be a retrospective system in which there's no support to change the delivery system financially, but yet we all expect a different outcome.
Lots of questions for later. We will let you get through your presentations, but just one early question is a recent analysis we heard at our last, one of our last public meetings was that roughly 5, in some states, a little higher % of premiums actually goes to primary care providers, and some states now are setting targets, 1 up to 11%. Mm-hmm. Turns out in Vermont, we're about 5.7% of premiums going to physicians. How do you think about such a number or a target for Blue Cross Blue Shield?
It's a really great question. And I think that 2 things. I think that every time we think about the challenges in healthcare delivery, we correctly, and I think to some degree burdensomely for primary care providers, turn our attention to them. I think that we need to increasing the amount that we pay to primary care providers, and incidentally, Blue Cross did a 5% increase for primary care providers across the board about 10 years ago, simply because we saw ourselves falling behind on those sorts of benchmarks that we do look at. We thought it was the right thing to do. I think that we need to identify specifically what the role of pediatric medical homes and primary care providers will be in a reformed delivery system, and then we absolutely have to fund it. And instead of 5.7%, maybe it's 8%. But I think that we have to have some alignment between what we're going to be asking them to do and how much we're going to pay them. And we absolutely need to align what we're paying them with the investment that needs to be made and what our expectations are going to be. So I think, the great thing about healthcare reform is we kind of throw out those benchmarks that we may have been looking at that suggest that primary care physicians represent about 5 to 6% of what the delivery system is. We have to be open to the idea that it might be dramatically more, but it does need to be aligned with what we're asking them to do and the outcome we think we're going to get from it.
Any other questions at this point? Okay.
I'd like to hear the rest of the presentation.
I've just about used up my time, and this is my last slide, so that's
okay.
good.
We interrupted you.
I just wanted to briefly let you know, so what are we working on at Blue Cross Blue Shield of Vermont? What we've focused on this January, in addition to what's on the far right, which was something we worked on last year and shared with our board at a retreat, which is Vermont's Health and Wellness Company, we're focused on what we call Business Transformation 2014. We've already talked with Mark Larson and people in his agency about the work they're doing to set up the exchange for Blue Cross Blue Shield of Vermont, because we're a Vermont company. This will require some significant moving around within our own organization. We have 200,000 subscribers, and we could have anywhere from 770,000 to 100,000 enrolling through the exchange in 2014. So just the function of our organization, in order for us to be most optimal in the way we service those people, will need to change. And that's really an internal function, and we're working on that. The other thing that we're focused on this year is what we call a retail strategy. How are we going to support people? We have largely, for 2 decades, been a business-to-business company. Businesses purchase our products and we service them as businesses, even though we focus on member experience and on those members. But the person who pays the bill, the ultimate customer, about half of those people are going to be individuals. And so we're just not taking an old business model and ascribing it and overlaying it onto individual subscribers. We're actually thinking about what our outreach is, how we service those people, what our technologies will be that we wrap around this, because we see it as a very different environment if we're going to make the contribution that we'd like to. So those are the big things we're working on.
Not to put you on the spot for a number, but maybe you could get back to us, but with the exchange, there's the option for companies to no longer offer insurance, and then their people would go and use the exchange as individuals. And I'm not sure if that's what you're referring to. But have you run any numbers do you have any crystal ball looks at what you think that out migration will be?
We ran numbers as soon as Act 48 passed. We ran what we call Simulation 2014. I would absolutely call it a very rough, sort of aggressive first pass. Catherine, you were involved in that. We had sort of uptake numbers and things of that type.
We think that the migration could be as high in Vermont as 40% of small businesses dropping coverage. It's going to range by the business size, and as you know, about
Stuart left the room, so you're
half of the businesses
I
are
waited.
under 10 people. Half of the consumers and businesses are under 10 people, so they're very small businesses. So there's a number of ranges in the industry, and that's the one we sort of landed on.
And so the question that you have is, how do you educate them as to who you are and what you offer through an exchange or through advertising outside of the exchange, but that gets them in the exchange?
We think that the support for people who will be individual purchasers in 2014 will really have to be heightened during that year. We're planning on both programs and an investment, particularly for 2014 and 2015, that we don't think will have to be sustained in the outer years. But we think the success of the overall reforms and exchange work that's being done in Vermont will be the outreach, the explanations, the work the state and Blue Cross would do would be absolutely critical in 2014.
Thank you.
Catherine, I'm happy to turn it over to you.
Yeah, thank you very much. I also wanted to say we appreciate the fact that you're cooling the projector by blowing hot air across us here as we sit here. At first, I wasn't sure if I was becoming feverish.
That's why we call it the hot seat.
But it's nice on this.
If the meeting goes well tomorrow, we'll put the table on the other side.
I do appreciate the opportunity to take in the next 20 minutes or so to provide basically an overview of the business of our business, how our company works, who we serve, etc. You know, I would start by saying, if it's not apparent to you already, and I know some of us know each other in the past and know already, but if it's not, it soon will be, that we're very proud of Blue Cross and Blue Shield of Vermont. You know, by Vermont standards, we deal with large numbers. We insure or provide coverage, as Don suggested, for roughly 200,000 Vermonters. We pay something on the order of $800 million a year in health care expenses. We process over 2.25 million claims each year. And in doing all that, occasionally something goes wrong, that's for sure. But we try very quickly to correct it. Things don't go wrong very often. By all measures, we operate on a small scale here in Vermont, among the highest levels in the country in terms of the business of our business. And we always recognize, as Don suggested, that we are in Vermont, and just as Vermonters, and when we're on vacation and we walk into the airport for that last leg to Vermont, we can know with some certainty that we're going to know a few people in the gate there. Likewise, when we're answering the phones or solving problems or signing people up, we know that there's very rarely more than 1 or 2 levels of separation between those folks who we're providing services for and someone in our family or someone in our friends. So we do feel very proud of our company. And you know, it starts almost kind of back at the beginning. And when in providing an overview of the company, I want to talk a little bit about how we are different. And we are different because we were effectively created by the state of Vermont. Some of you may remember that back in the old days, prior to the mid-1980s, there was no Blue Cross and Blue Shield of Vermont. There was a Blue Cross and Blue Shield plan here, but it was an affiliated plan with Blue Cross and Blue Shield of New Hampshire. All of the major operational functions of the company were located in New Hampshire. Almost all the jobs. We had a very small kind of storefront here for provider relations and marketing. All the claims were processed in New Hampshire. It was the wisdom of the policymakers and regulators at that time in the 1980s that Vermonters could be better served by having an independent Blue Cross and Blue Shield plan here. The concern was that the jobs associated with all this health financing were accruing to New Hampshire, that Vermonters could be subsidizing folks in New Hampshire through the payment of their premiums. So the legislature created in statute a provision which effectively created a nonprofit hospital medical services corporation, and that's Blue Cross and Blue Shield of Vermont. We exist in statute, the way I describe it. We were created as an instrument of healthcare reform. It's worth noting, and you know, I have two challenges here today, and they're both kind of significant. One is to try to answer your questions, and the other is to try to do this in 20 minutes or so, because on everything I'm going to tell you, I could go off on an offshoot, and Catherine reminded me of that on the way down here. But I will note that when we hire new employees, we gather them together on about a quarterly basis, right? All the new employees who've been hired in that quarter to give them an overview of our company, and we start right here. This is how we were created. This is what our mission is, to provide health benefits and financing for Vermonters. We're not for profit. We have an independent board of directors. We're a member of the Blue Cross and Blue Shield Association, but all the decision making, all the business is conducted here in the state of Vermont by our 341 employees. We are regulated differently than the other health insurance companies. We have direct contracts with our subscribers, so every subscriber who's insured through us has a contract with the organization that gives them certain rights. And for the entire time of all this, we have been the only company, because this is part of our DNA, the reason that we were created, that we have on an uninterrupted basis offered health care coverage on a non-discriminatory basis to all segments of the Vermont population. Why that's important is the insurance industry, as Don described, often comes in and looks at certain market segments that they think that the industry feels that it can operate in profitably or perhaps well. And there's been traditionally certain segments of the market which are harder to serve. They're harder to provide financing for various reasons, which I won't go. Blue Cross and Blue Shield of Vermont, since its creation, has always provided and offered on a non-discriminatory basis health coverage and financing to all segments of the Vermont population. I'll come back to that in a second. Very, very quickly, because this does get to some of the questions you answered. Our administrative expenses, as you can see from this slide, we are proud that over 90 cents of every dollar we collect goes right back out to providers for the services, the medical services they provide to our members. Across the entire book of business, about a penny that we collect goes to compensate insurance brokers and consultants who work with businesses to help them understand their options and, frankly, to administer their health benefit programs. The cost of running the business, so to speak, is about 7.4% of that dollar. And across the book of business, we contribute about 7 cents on the dollar to our reserves, which we're required to maintain for the protection of our subscribers. I thought we won't have to spend but a second on this slide, but another Blue Cross and Blue Shield plan a few years ago did a survey on what the common understanding was of consumers about how that dollar was split. And the common understanding that was about 50% went out to benefits, and the rest of it went either to administrative expenses or the profit or reserve requirements of insurers. So the fact is that might have been true, or might be true in some parts of the country. It's not true here in the state of Vermont, certainly not with Blue Cross and Blue Shield of Vermont. We're pleased that over the last few years we've been able to actually reduce our administrative expenses, not grow them, while we're growing the business, and I'll talk about that in a minute. We are growing in our membership, et cetera, but through very disciplined management under Don's leadership, with clear direction about what we want to accomplish. We've been very focused about our investments, and we have reduced our administrative expenses by over $9 million in the last 3 years. It's worth noting that, as you see it come down to about $60 million in 2011, we expect it to level out there because we need to make investments over the next couple of years. We need to build back in and make investments to prepare for the exchange, to do the types of things that we just discussed, to try to have an infrastructure that we can use to help members understand what options they have and support their transition, etc. To continue to invest in our IT systems as more and more of the business moves over to an electronic platform. You know, the MLR and MBC and RBC things, you asked about our reserves. You can see at the bottom of the slide, the reserve slide, it's showing at about $124 million at the end of this year through our forecast. The more important number from our point of view is the RBC number. It's called risk-based capital. Mr. Gobet, I think you asked about this at one of our earlier meetings and proved once again that it's almost impossible to explain what risk-based capital is, but I'll give a very high description, and that is risk-based capital basically is the amount of capital that an insurance company needs to have based on the elements of risk within this business. So I'm going to show you this in a minute. Blue Cross and Blue Shield of Vermont has a fair piece of business. It's in what we call cost plus, which is a form of self-insurance. Our risk exposure and risk and reserve requirements are lower on cost plus pieces of business than they are on fully insured pieces of business. The reserve requirements are higher on our individual market segments than they are on our group market segments. So the RBC attempts to reflect those different risk characteristics and assess the overall health of a health plan. Our risk-based capital is at the highest point in its history through 2011. In 2012, for the second straight year, we've enjoyed significant growth. Because we now have risk based on significantly more members, the RBC level comes down, and our forecast for this year is about a little bit under 600. The Don has directed that he thinks, and Don, I don't want to speak for you here, but the 500 to 700% RBC level is about the adequacy range for Blue Cross and Blue Shield. We don't want to have over 700% RBC. Below 500% RBC, and it begins to get awkward and uncomfortable, because as you get lower and lower in the RBC, you hit tripwires. You know, you get the notice of the Blue Cross Association, which becomes concerned whether you'll be strong enough to be a Blue Cross and Blue Shield plan. At a certain level, you get the attention of the regulators because they're concerned that you won't be able to meet your future liabilities, etc. Our membership, I've said that we serve every segment of the population, and indeed we do. You can see the slide here. On the, there is the large group side. We insure large businesses and associations. That says large group insured. It's really not. That's a little inaccurate. This is large group, both insured and self-insured. About half of that, a little bit less than half of that, is in self-insured programs, and a significant piece of that is the Vermont Education Health Initiative, which is the school districts, the management and organized labor of Vermont school districts have come together and manage a very, very well-managed self-insured trust. It's the largest single purchaser of health insurance in the state of Vermont. On the small group side, we have about 45,000 members. It's worth noting that about 34,000 of those members currently purchase through associations, through trade and service organizations, like the Chambers of Commerce and the Grocers Association and the Dental Society and the Medical Society and the Retail Association and things like that. That has been an important component of how small businesses access health insurance. The individual market segment, you know, we have what I think of as our traditional non-group pool. It has been a difficult pool to serve for selection reasons. You know, if you don't have group health insurance and you don't have an employer who's paying part of the premium and you're paying the entire premium out of your pocket, then you kind of make an economic decision. And the economic decision is whether you have a sense that you're going to have more in healthcare expenses in the coming year than the cost of the premium. Folks are pretty good at this, actually. They're pretty intelligent about those decisions. So because of that, you find that younger folks, healthier folks, tend to not buy if they don't get in group. Older folks, of course, do buy it because they know the exposure. So it's a more difficult pool to serve. We have about 1,000 or a little more than that in our traditional non-group pool. We have, we were partners with the state in the development of Catamount Health, and we continue to be very proud of that program, a public-private partnership. Today we have over 13,000 Vermonters who at one point had been uninsured who are currently part of that individual market. We have Vermonters over the age of 65 in both our traditional Medicare supplement products and Medicare Part D, et cetera. FEP is the federal employee program. We have about 14,000 federal employees in the state of Vermont who purchased through Blue Cross and Blue Shield of Vermont. They're offered an array of products through the federal program. And so as I say, to every segment of the market we serve, we have some of the demographics because you asked about them. The average age 43, about 54% are females. You know,
What's the average age, how much higher is it for your non-group pool? You know?
I have those numbers. Let's see here. The traditional non-group is up in the 50s. Catamount is 43, so it helps bring the non-group down. Worth noting that our med supp, the average age is 80. You know, and so we do have the entire spectrum. Before I move on to the next slide, which is about the number of rate filings, I thought I would take a moment here, and I'm mindful of the clock, to talk a little bit about how the premiums are developed for these various pools, because it is, I think it's important to your work and perhaps interesting to understand about us. On the large group side, any group that has more than 50 employees at this point, we use their actual claims experience in the development of their premiums. At 50 employees to 100 employees, we don't use much of it. We assign them about what we call 20% credibility. But there's an element of their own experience that goes into the development of their rates. The bigger an organization is, the more credible it is from our point of view, and so the more of the more its rates are based on its own experience. So when you hear, people ask, well, what are your rates going to be next year? Well, it's an impossible question to answer. What we can say is what the trend is going to be, what the average overall medical cost increase for the population is going to be, because within that there are groups whose experience is higher than average or lower than average. On the small group side and the individual side, we are community rated and always have been. We partnered with the state in the early 1990s, another thing that we're quite proud of, in addressing and making Vermont one of the first states in the country to become community rated in the individual and non-group markets. Back before that time, you had a lot of health plans in Vermont which would offer rates, very low rates, to young, healthy individuals, and would refuse coverage to folks who'd had a previous medical condition, or refuse coverage for those parts of the anatomy that had previous problems. There was I recall when this was being debated in the Vermont Senate, a senator standing up and reading one of the medical questionnaires of an insurance company. And basically, if you'd ever had back problems, you could get coverage, but nothing for musculoskeletal injuries or illnesses would be covered. That was the situation, and Vermont moved away from that many years. The rest of the country, with the passage of ACA, is moving away from that, and Blue Cross has been a part of that. So you'll also know that, well, wait a minute, you've got all these associations, though, and they aren't community rated, right? They have their own rates. The associations actually are community rated, but they're community rated within their own pools. So, for instance, well, if I might use an example, the Vermont Chambers, they have a different rate than, we'll say, the Vermont Health Service Group. But the rate for the Vermont Chambers is based on the experience of all the members within that association. And the association has to abide by the same rules that Vermont has passed on to insurers. And that is, you have to accept anybody who meets your membership requirement. You have to accept them for coverage. You can't vary your rates based on the characteristics of the folks coming in, so you can't game it that way. So they're experience rated, but they're community rated at the same time. I thought that might be useful.
So Kevin, those monthly premiums? That's a blend across all?
That's across all the business.
And could you give us a trend on what those have been over the last 5 years or 10 years, if you average it across all
we can.
lines of business?
We can.
Okay. Be interesting.
We do a lot of filings, and we're working with some of you on this board, and we've made some recommendations to the Department of Banking and Insurance about reducing the number of these filings, as you can see. At the large group side, once again, I'm mindful of the clock. We don't submit every large group rate right now for approval, but what we do submit is all the factors that are used in the development of those premiums. So the state of Vermont approves our administrative expense factor, It approves the relativity factors, the difference between benefits and products. It approves the trend being the biggest component of the projection of future healthcare expenses, et cetera. We file various factors. There's 11 different filings over the course of the year. We do file specific premium levels for our small group pools, for our community pool, for our individual pools, as well as for the associations. So the state currently reviews and approves the premiums for small group individuals, Medicare supplement, and associations, and the factors used in the development of premiums for large employer groups. We're very pleased that our market share is growing. We had roughly 8% growth in 2011. We expect 8 to 10% growth again this year. There's a lot of factors involved in that, but at least part of it, I think, is the validation we think of the work that we're trying to do to be an outstanding partner. We do see our customers as partners and our members as partners, and understanding their needs when we develop our products and services. And you can see that if you look at Blue Cross and Blue Shield of Vermont and TVHP, which is what we think of as our core business, the out-of-area Blue Card, which I'll talk about in a minute, basically it's folks who are Vermonters who work for employers that are located or headquartered in other states, who purchase through their other states' local Blue Cross and Blue Shield plan and have a Blue Cross and Blue Shield card in their pocket. We administer their claims through the Blue Card system. And our CBA Blue company, which is a third-party administrator, basically a claims administrator that provides financing of coverage for roughly 20,000 Vermonters, we have somewhere between 73 and 74% by our estimation of the commercial market. So at this moment in time, we're very pleased at the extent to which we can fulfill that mission that I talked about in the first slide, for which we were created, which was to provide health benefits and financing for Vermonters. It's the only reason we're here.
Kevin, 2 words on the distinction between Blue Cross and TVHP.
Blue Cross, it's easier to start with TVHP. TVHP is an HMO that we created in partnership with, and Don was instrumental in the creation of this back in the mid to late 1990s. We partnered with Fletcher Allen Healthcare, Rutland Regional Medical Center, Dartmouth Hitchcock, in the creation of an HMO. We did not have an HMO at that time. An HMO, which I can describe as kind of almost like a closed network of providers who share risk for the medical care that's being delivered to their members. It was a kind of a Vermont experiment, really, in a Vermont effort to respond to a market where giving providers more tools to manage the care of the members and have them share the medical risk or the financial risk for that as well. Not by the insurance company creating the HMO and imposing it, but through a partnership. Over time, Blue Cross has assumed that. Frankly, the HMO products are not as attractive or as often used as they were. More and more folks who purchase through the HMO purchase point-of-service products, et cetera. Blue Cross and Blue Shield of Vermont is the traditional kind of where we have our PPO products, and I should say, and it's important to say, that it's all administered by the 341 folks who I talked about before. All the combined numbers are in those numbers that I described before. It's just kind of a different product line at this point. We've talked about our focus on service and kind of how we try to remember and teach ourselves all the time that there's a member on the other end of every problem. I did think that we should talk for a moment, before I pass it on to Catherine here, with time waning, about the coverage of folks that are out of state, because it's kind of an important issue. Everything I've described up to this moment talks about us as a local Blue Cross and Blue Shield plan, and all of that's true, and we're very proud of it. But it's also very important to know that we are an affiliate of the Blue Cross and Blue Shield Association. I think of it almost as a franchise. In order to maintain our affiliation, we have to provide service at certain high levels. We have to have financial strength at certain high levels, and that allows us to basically partner with the other Blue Cross and Blue Shield plans across the country in using their networks or kind of weaving all our networks together so that when our members travel across the country or across the world, they have coverage, and we can continue to provide them with the same level of service, as Don said, whether they're in Kenya as they are here in Vermont. It's not an insignificant thing. You can see that from the slide. There was about 170,000 visits outside the state of Vermont by our members last year. Now, 121,000 of those were to providers that we have direct contracts with. So those, as a local Blue Cross and Blue Shield plan, we can directly contract with providers in contiguous counties of other states. That includes Dartmouth, Hitchcock, and some of the providers up and down the border. So a big part of that 121,000 is the care that goes there. You can see that's over 48,000 visits, more than 20,000 members. And if you really look closely at the very small print there, which I can't see, I think it's on the order of about $50 million worth of care. It's not even in the contiguous counties. This is care that's being provided across the country and across the world to our members. So it provides great value for them. You've asked about kind of how we establish what's covered and what's not, and what the appeal processes are. This has gotten some attention recently. It's something I'm frankly happy to be able to talk about. You know, we have a certificate, what we call a certificate, which is the contract which I described at the outset here. We have a contract subscriber, and that contract attempts to tell them what their covered benefits are. And it goes with an outline of coverage and a few things like that. It's impossible to put in a contract every type of service, every type of thing that might come up in the course of somebody's medical care. Frankly, you'd be hard-pressed to find somebody, I don't know if you've looked at these yourselves, who says the contracts are not confusing as they are. But it's impossible to predict or forecast or project every type of thing that might come up. So what we do is we take the covered benefits, and then we have medical policies. We have a medical staff of doctors and nurses, a chief medical director who works with providers across the country, with providers in the Blue Cross Association, with databases, et cetera, to develop medical policies. What we do is you know, when somebody goes for a medical service, if it's covered, you know, we just pay for the service. If it's not clear, we apply the medical policy to the covered benefit and make a determination.
Kevin, do you have a definition of medically appropriate care?
I don't have it with me, but we certainly do, yes.
I'd love to see that.
We'd make that
I'd
available.
be happy to follow up with that. You know, it's important to note here, it goes without saying, but I'm going to say it anyway. This is, because around the country, you know, you hear about all this. This is not a process designed to serve as an obstacle to anyone getting medically necessary, appropriate care. Our business is to assure that they get medically necessary, appropriate care. It is a process, though, to support the delivery system in that goal of making sure that folks get medically necessary care. In the event that a determination, and this is very, very rare, you know, I told you we have 2.3 million claims a year, right? In the event that there's a determination that says, well, no, that this thing that was recommended is not good medical policy, we're not going to provide coverage for it, the member has what we think of as a robust process to kind of take a look at that. There's 2 levels of internal review. They can just ask for it to be taken a look at again. They can have an internal review process where they can come in, they can have their provider come in with more information, frankly. Now, when you think of that process, you can think of, well, they have to come in and kind of convince us. Actually, it's a very useful process for both sides, because in the adjudication of 2.3 million claims, on claims that for medical services, diagnostics or treatments or drugs that aren't not clear, frankly, not a lot of information comes with the claim. So the review process allows the provider, the member, to bring more information to the table. And that information is often quite useful in our consideration of the claim. There's an external review process. If the determinations that have been made through those processes still result in an adverse determination to the members, it goes to an external review process. The external review process involves providers in the subspecialty of the specialist who's made the recommendation. The decisions of that external review process are binding on us, not binding on the member, by the way, but binding on us. And if the external review process results in an overturn, so be it. And then finally, of course, there's everybody has the right to take their appeal to the court system. The next slide shows the volume of appeals and the top 5 reasons. We worked very hard because, you know, a lot of these appeals are based on, you know, maybe folks didn't have, you know, the right information, et cetera. As you can see, the #1 reason for appeal is kind of network issues. They went out of network. Sometimes folks don't know because they have employer-based health insurance that their employer purchased a plan that requires kind of the care to be provided within network, and they go out of network and they run up and it's not, and so they appeal that. Prescription drugs, there's a lot of, my quick arithmetic said we process something on the order of 10 claims a year on average for every member we have. And most things that we measure, if you ask me how many emergency room visits it would be, but we have so many per 1,000 members. How many maternity care, so many per 1,000 members. How many, surgical procedures, so many per 1,000 members. Prescription drugs, it's so many per member, right? We have several per member prescription drugs, so there tends to be a lot of questions about those. Radiology, et cetera. Somebody gets a recommendation for a PET scan when the science suggested a CAT scan might be sufficient. There's conversation back and forth, and so what we've tried to do is through both communication to the member, communication to providers, identify those things which are really being appealed because of lack of understanding of how things work, and you can see that the number is coming down. So something on the order of less than 2% of all the claims that we receive result in denials. It's a little bit higher number than that, but when you take out the numbers of duplicate claims, because we get a lot of claims that are sent in twice.
Why the threefold change?
I'm sorry?
From 3,800 to less than 2,000?
That's
What accounted for that?
That's what I've described. Us trying to go out and identify those things that are driving the appeals and provide further information about them, and frankly, in some cases, look at our requirements, et cetera.
We put together a team because we were concerned about the increase to focus with our support on decreasing the number of grievances and appeals that we had. Some of it was outreach that we had to do with our PBM, our pharmacy benefit manager, to more align their programs with ours. And we're very pleased, as you can see, with what the team was able to do.
It took a little bit more than my allotted time as well, but let me pause there and either ask for questions of me or turn it over to Catherine. Maybe we can come back to general questions. I'm very pleased to have the opportunity to talk about this.
Go ahead.
Thank you. I'm going to talk a little bit more about healthcare management and our approach to that and how that's different too at Blue Cross Blue Shield of Vermont. I'm also going to talk about 2 of our largest projects. One, ICD-10, which is something you asked about specifically, and the health insurance exchange and transitioning the individual and small group markets into the exchange. Our strategy within healthcare management has been described really well by both Don and Kevin. In essence, it's about supporting the delivery system and not getting in between patients and their providers. For us, it's not about the either or, and by that I mean it's not about health cost management or member satisfaction. We try to consider both. And it's a challenge. I actually think it matters and makes a difference that our staff at Blue Cross Blue Shield of Vermont are also the neighbors of the people that we serve. I think having a local company does make a difference. And we as executives get a chance to listen to the calls on a frequent basis. And not only the support that comes through, but the compassion of our staff always impresses me, as well as their ability to navigate what is such a complex world for everyone in it. I'm going to talk, as we all know, there's significant healthcare costs at both the beginning and end of life. I'm going to talk about our beginning and end of life programs specifically. Better Beginnings is one where we lead the nation. Both as a state and as a health plan, we help to drive those results. And I can speak from personal experience here as someone who had twins at 40 and a graduate of the program. And I had a Better Beginnings coach, not just because I was an employee. All Blue Cross Blue Shield of Vermont customers have this, who coached me throughout my pregnancy and helped me to deliver at 38 and a half weeks to healthy boys. And then when I got to the hospital, I was impressed that the nurses on the 5th floor of Shep said, "Do you have Blue Cross?" of Vermont? And I said, yes. And they said, thank goodness, because the support that I received in transitioning back home was extraordinary. So they sent a lactation consultant to my home that prevented a hospitalization of my son James. And they also sent a VNA nurse out. So it was very much of a supportive to the delivery system and to my OBGYN. That program is tailored to the needs, the individual needs of the women in the program. So that was tailored to me, a 40-year-old having twins. We do surveys with the women up front to determine what their specific needs are, which vary, obviously. The second program I wanted to talk about is our end-of-life program. And as you know, at least in Medicare, about 40% of Medicare costs are consumed in the last 30 days of life. So this is an extraordinarily high-cost area of care. And it's also an extraordinarily difficult time in our members' lives. What we have learned is that about 98% of our members at the end of their lives would prefer to die at home. But often there's a lack of understanding of the resources, the palliative care resources, what is covered. So often what we're doing is coaching and counseling those families in a very extraordinarily difficult time, and working with the physician community to make sure that those services are covered. And the results speak for themselves in terms of trying to meet the needs of those families.
Yeah, if I can't help but jumping in. I've actually done a very good job so far. I'm not doing that. And but this is one area that, as a state of Vermont, we could focus on. I met once with an end-of-life expert who had written a book, and he said something to me that's always remained in my consciousness. He said, "We die like no other country in the world." And this really does take hands-on. It's personal, which healthcare is. But you know, for the most part, our nurses are reaching out and working with spouses, not necessarily just the patient themselves. And I do get letters from our members that run both ways, that ask us to do things differently, but almost an equal number that thank us for things that we've done. And I will always remember a letter. I get letters all the time on the end-of-life care program. I wish it could be on some other type of program than that, but I got a letter once that said, I'll never look at an insurance company the same way again. So we do think healthcare is personal. These are two programs in which it's about reaching out and engaging with patients in a highly personal and different way.
And the nurses who do this are in Berlin?
The nurses that do this are in Berlin. They're certified oncology and end-of-life case management nurses.
So to introduce my next segment, which is on health and wellness, and I will try to expand on Don's earlier comments, we all recognize that unless we tackle consumer behavior around what it is, our levels of activity, and what we eat, frankly, we are not going to address in a meaningful way health morbidity, preventative morbidity, or healthcare costs overall, no matter how good a job we do at reforming the market or reforming reimbursement. So this is the world that we are investing significantly in. We are beginning and we are establishing a track record in this space. There's significant demand for the wellness and condition management services at employers. And we have a new product, as Don mentioned, that is out in the marketplace, and we've already made some sales and have some new prospects. We have been, as Blue Cross Blue Shield of Vermont is an employer, a large employer in this state, we have been walking the walk with our program over the past 3 to 4 years. And one of the things we've learned is that these programs need to be accessible, not just to the athletes in your company, but to the smokers who are out smoking at 0-degree weather. They need to be accessible to people who are already overweight and maybe have never been to a gym. And I'll give a great example of that. We just started giving out free fruit on Wednesdays. And one of my colleagues said she had a banana for the first time in 20 years. So it's going to take time. Awareness is absolutely key. So raising people's awareness, one of the things we're really committed to is everyone knowing their numbers. So the biometric screenings are key, and making that easy for people, making that something that you can do at your work site. The environment of the work site and the culture of that organization is absolutely key. So having a committed leadership around wellness is important. Making it relatively easy, so doing some internal marketing for people that we do have healthy offerings if you have a cafeteria. making it, adding some financial incentives, and $500 is the magic number out there in the research. It certainly has worked in our company. We've seen, we have 95% of our employees doing biometric screenings, which is off the charts high in terms of participation. So the first wave of any of these programs is to get people engaged and aware. The more you can do that in your work site, the better. We do use a vendor called Healthways to do our health risk assessment. We partner with the VNA for the on-site screenings. But we've also been doing, we have an on-site, full-time worksite wellness person who's fantastic. And you may even want to hear from her in a bigger way on what she does. And she goes across the state to employer groups. She trains trainers. She does wellness planning with businesses that involved with that assessment that Dawn spoke about. So they assess the workplace, both the environment and the programs in place, help them understand their measures and their, the data and analytics is important. Where is your population today? Where do you want to move them? So a lot of the data that we have today is on our own Blue Cross. It is relatively early because today we're really measuring participation, right? I think tomorrow we'll be measuring health cost savings, and I'm convinced that they when done right, we're going to start to see trends move
So are
for
you
the
tracking that for
customers.
the employers who buy these products?
Absolutely.
You track their
Right.
claims
And we are
costs?
actually providing an incentive up front because we believe so much in the program that if you go enter into a contract with our accountable care product, that it will produce cost savings, and we're willing to put money on the table as well. So there's accountability both among the health plan and the employer. Phase 3 is to bring provider accountability there with special contracts that would include incentives for the management of the health of that population.
This is what we see as really needing to be different from some of the health reform paradigms we've been involved in the past. 15 years ago when we created TVHP, we did risk contracting. We turned the issue, and frankly, for lack of a better way of putting it, the problem over to providers without any real consideration for how prepared the patients were to be working with them in an integrated system and in a different way. So I read on your very well-crafted op-ed in the Times-Argus this past week, and I'm quoting your quote, that they, meaning providers, need patients whose expectations and personal behavior are consistent with a system that rewards value. And when I read that, this is really what we're trying to do, is to be responsive to that. So we really think that we're committed to that our members, our customers, need to participate, are willing, and are stepping up to participate in this so that when they enter integrated systems of care, they're prepared. And the physicians that see them are getting an advantage from that.
And the good news is that a lot of employers are very interested in this for obvious reasons.
As you move from participation to measuring health cost savings, how will you look at improving health? You referred earlier to secondary prevention, primary prevention. How will you look at workplace wellness in terms of improving health?
Well, we have actually scoped out what we would call a scorecard for employers in the program, and it does involve many of the standard measures you're probably familiar with around NCQA. So measures of basically prevention and wellness, and some outcome measures related to the treatment of chronic disease and the timeliness of that treatment. So that's sort of our interim step. And we assume that when we bring those numbers up, as well as the numbers of the population, including BMI and blood pressure, and we move those numbers in the right direction, then we will see improvements in health costs over time. But it's a longer-term commitment. We have a 3-year model with different milestones each year for the employer to advance their strategy.
Do you see any applicability for the non-employer customers?
Absolutely.
Yeah. We're trying to develop a model for January 2013 that would provide the same incentives, goals, measurement at an individual level.
I just had a couple things. First of all, are they allowed to quote us to us? I mean, that's a dangerous precedent, Con. I mean, you got 70 years of data out there. So we're going to let it go this one time, but okay. The second thing is, and you don't have to answer it right now, maybe you could do it at the end of the meeting, or you could do it at a more informal time, but if you were king, how would you put all of these things together, and what would be the best way to reduce cost in the overall system.
Mhm.
Before you say anything, Nancy Turnbull was here, was it only a week ago? Wow. She was here, and I don't want to put words in her mouth, but I took from her, and anybody can give me feedback, that her feeling was that I'm going to, like, hospital global budgets or a global healthcare budget was the grand solution. And can you pick that apart, or as king, say that's it, or where do we go from here with that?
What we've consistently said is it's about comprehensive health system reform. So not any one thing is going to be a magic bullet. And I think that I've participated in enough any one things and treated them like they were magic bullets in my, all my years in Vermont, to learn that it's really about every aspect of the system moving at the same time. Responding to, if we could have it our way, what would it essentially look like? I would love to have a separate discussion. I think that in short form, what I would say is what you're hearing from Blue Cross Blue Shield of Vermont is this is a space we can live in, the relationship we have with our members and with our large group customers, that we think it would be very beneficial to the providers as we pull back our care management program, so we're no longer perceived or actually in their way of care delivery with their patients. So it's doing things in a way that are complementary, in a way that you're willing to stop doing certain things and re-energize yourself in doing other things. And we see ourselves in this is a space with our relationships we can live in very effectively and to the benefit of the delivery system as we systematically begin to pull back other aspects of our programs. And I think it's making sure that it's all engineered. It's like a fine clock. It's ticking together.
One of the, call it technique or whatever, that we're applying to the first round of our hospital work is trying to connect hospital net revenue increases to more closely to true economic indicators. We haven't sealed the deal yet, but I think we're pretty close. We can see, at least in that one sector, a march toward sustainability, using that as a kind of a benchmark. Can we do the same thing in your world? I mean, what is the sustainable level of increase in healthcare that we can all live with?
And when you say in our world, do you mean
the total healthcare world?
The total healthcare cost?
Yeah.
I think that I think that our goal for total healthcare cost is to have it more readily approximate overall consumer price increase inflation. And I think that is the proper place for us to start, and we shouldn't give up on that. I do think that it will take once again, I'm reiterating what I just said. I think it will take some delivery system change in recrafting the way we deliver care. But I also think it's absolutely going to take our refocusing on the way we consume care as well, too. And that, you can see, that's been a big focus of us. And so I think it's both in the delivery and the consumption of care that we can get to that with a dose and a modicum of sort of expectations along the way. And I don't think that it's quick. Has been my sense. I don't think we're going to get there in 2 years.
Right.
I don't think we're going to get there in 2 years. But if we can't, then I think some of the charts that show us by 2040, essentially with our gross domestic product being entirely healthcare, are accurate. And so.
And related to Al's question, one of our charges as a board is to actually create a healthcare budget, if you will. I mean, that's very clear in Act 48. Can you envision that?
Envision having a healthcare budget?
Yeah.
I think that we have budgets for everything, in our own organizations, on smaller and on larger levels. I think having a healthcare budget is a desirable and healthy part to this process. I think the question for me becomes, what happens when we exceed the budget in any given year? What happens when we come under the budget in any given year? I have said that I think that although I don't think of us as an insurance company any longer, I do think that whatever we do in healthcare reform in Vermont ought to be backed up by reserves, really on almost the insurance company sense. Because I think that it helps us take beyond the worrisome concern that if we somehow exceed a budget, that care delivery stops. So I do think that crafting and working towards a budget is an absolutely desirable thing. That's what a global capitation is. I think we ought to stay committed to healthcare reserves so that we're able to move beyond. So what happens when things happen and we happen to go beyond the budget in any given year?
Basically, you would include reserves as a line in the budget. I mean,
I would include reserves to answer the question, what happens if we unavoidably go beyond a budget in a given year?
Okay, that's good.
Yeah.
I was just going to offer, another thought. It's implicit, and I mean, you can budget at any level, right? I think it's implicit in all this, and it's implicit in what you've seen from us. I think that somehow we have to improve the health of the population. We have to reduce the number of folks who are developing one or multiple chronic diseases, right? Because we're going against the tide here. People are getting older. Absent some kind of change in our health status,
No,
the budget exercise alone.
You
won't
might
do
be
it.
getting older, Kevin.
I am. I would.
That sounds like a good transition.
Well, and I heard the sad statistic on Wait, Don't Tell Me, a very good source of information this weekend, that 50% of our dogs are morbidly obese.
Not my fault.
So it's not just us.
We give our food to the dogs.
Well, see, that's what ends up happening.
I have a couple more slides I want to go.
I'm
Okay.
sorry, we're sorry. Yeah.
And it's a very exciting slide of coding.
Yes,
Oh,
ICD-10,
great.
everyone's
So
You asked about back to
all right,
this.
so we're going from 10,000 to 70,000 codes, which could mean good things for you beginning in October of 2013. You have better data going in.
But nobody will be able to interpret it
Diagnoses.
for
But I
at
did want to
least
point
5
out
years.
that our favorite ICD-10 code, because they're going to have codes for everything, is struck by an orca. We don't think that we're going to see a lot of that. It's WSG.22XA if you need the citation, except perhaps someone on 89 hitting the whale
You
tail.
think people just insert things like that to make sure we read this stuff?
Could be.
Perhaps.
It's a bunch, they hire
They're
a bunch
out,
of guys
they
that went
are
to Knowles
out. We
University,
could
they sit
do a
around drinking
study,
beers. Yeah.
because these codes are in use in Europe. It is a huge effort, and we are, again, supporting the delivery system to raise awareness, help reduce anxiety, and provide education to providers in partnership with the Medical Society. And we have a training program. We're having them all throughout the state in March. If you'd like more information on that, I have that today.
Could I just ask a question about that?
Sure.
Without giving any proprietary information away, what's the order of magnitude of investment that you have to make?
It's our single
make this
biggest
work.
IT project right now. It's $2 million.
It's estimated each doctor will spend $10,000 to $30,000
Yeah.
a year on this.
Yeah.
Ongoing cost.
And we think by
Ongoing.
training,
This
we
will
can
never
actually
go away.
reduce the costs for providers as they transition.
Wow.
That's sobering.
Could I, what's the value that we expect to get out of this transition?
But we will have more specificity than
Yeah, I
ever
know that,
before.
but I mean-
So really, the value is informatics and reporting.
There might be some research value along the way.
Probably will be, yeah.
We're not doing a very good job of selling this. There has to be
I don't know
a
if
reason
this-
why. I mean, this isn't fair to whoever.
I think what I heard is the basic reason is that because other industrialized nations had implemented this so many years ago, there's actually some incompatibility between systems across the globe. And in order to really have a global health systems
Comparison.
information comparison,
Right.
the United States had to get up to what everyone else was doing.
So struck by orca might be applicable in Japan, is that?
Alaska,
If
New
you're struck by an
Zealand.
orca in Switzerland,
Oh.
but you're from Vermont,
I thought maybe
you can be covered.
Could we do this after we change the metric system?
So my final two slides are on preparing for the exchange, which is our single largest organizational initiative right now. We see the transition that's about to happen beginning in October of 2013, when the open enrollment begins, as being the most significant transition of the small group and individual marketplaces. We're viewing this in a very positive way. We think that exchanges have an opportunity to make things more transparent for consumers, to simplify their product choices, to make them more understandable and comparable, and to provide affordability for people who qualify for subsidies. And that's more affordability for Vermont as the federal government picks up those subsidies. We hope that we will cover more people in the process. We're aligning our products. We're creating a strategy that will involve a new distribution channel that's more like a retail channel, not just what we're going to be selling on the exchange, which you will also have an important role to play in terms of the essential benefit package, but also how we sell that, how we reach consumers, how we make sure that people who are eligible for subsidies are actually signing up. We have tremendous experience in this space already with Catamount Health. We have 97% of that market today, and we have a price advantage. We were very successful at attracting younger uninsured into that pool. We do know that we have our work cut out for us as a state because, as you know, as successful as Catamount has been, only 23% of people eligible for that program actually sign up. So we want to do a great job in partnering with the state to make those transitions happen. We know that we're going to have to change what we do and our business model so that we can be successful, in a successful operating model on the exchange. We're still waiting for some final decisions from the state on what the exchange looks like to really make that model operational, but we have already begun that work. We also hope to be a qualified health plan, and we think we're very well positioned. In terms of the impact on Blue Cross, we expect that 45% of our customers will be on the exchange in the first couple of years. It'll probably take a couple years to get everyone on. About half of the exchange is going to be made up of individual consumers, and 2/3 of them we expect will receive subsidies. 80% of the small group customers are now in associations. And there's a typo up here, but 80% of small groups are now in products that are actually have higher deductibles. So they're less rich typically than we will see on the exchange. And we are waiting for the fine lines here on the rules around the actuarial values. But what you can see is that within those 4 products, the richest product are the Platinum, and that's more like a Catamount Health plan today. The Silver product is going to be what the subsidies are based on, or the second lowest cost Silver plan. That's pretty much where the small group market is today in general. The direct pay market is typically in a bronze or lower market. So people are in relatively high deductibles today. So we're going to be transitioning them, and our challenge will be to ensure access and affordability as we do that.
What is their deductible usually?
The lowest deductible level we have in the direct pay market is $5,000. And in the small group market, the lowest deductible is $2,000. So the challenge will be, again, to make the transition and expand access to insurance as we do that, and not create issues of affordability as we do that. So we are prominently displayed as a partner to you and to Vermont on the exchange. We want to make this work with you, and we think we are well positioned. Of all the discussions you've heard from Don and Kevin around what it is that makes us different, it's reflected in how consumers perceive us. I must admit that nobody feels warm and fuzzy about their health insurer all the time. However, they rate us more highly than the national plan. We are number 1 in Vermont, and we're top 10 in the country in terms of our ratings. And so really, in closing, I just wanted to thank you for the opportunity today, and to hand it over to Don. Unless you had any questions for me before I do that.
When does Blue Cross Blue Shield of Massachusetts start selling through the Massachusetts
When did
connector? Have they already?
They've been, no, they have not begun yet with their small group,
Yeah,
have they? So
they did it individually when they first started, and they're slated to start, I think, this spring in the small group market. So they were about a 2-year lag into the small group market.
I don't know if this is because Catherine and I were on the VNA board together, but I want to thank you for mentioning the most vulnerable population and that we care for, and those that are near the end of their life, and how you are focusing on that that care plan that's feel so passionate about. So thank you for that.
Don, you done? You had some closing remarks up before we.
I promise my closing remarks will be very brief, and I'll be true to that. Just I hope what you've seen today is that since 2009, really before the Shao report, before Act 48, we were consistently advocating for a public-private partnership in Vermont to drive comprehensive healthcare system reform. That as you go through your important work, we really hope that as you discover opportunities, that you foresee challenges, that you will turn to that public-private partnership, and but more specifically, feel very comfortable in turning to us as a partner to help be part of the solution. We've stayed very consistent since 2009 about what we need to be and the changes we see need to take place in Vermont, the changes that need to take place in our organization. That's our commitment, that's our promise, and once again, I just close by saying we would hope that you'd feel very comfortable in turning to us as partners to be part of the solution. And thank you for the opportunity to be here today. We've gone a little beyond our time, but if you have questions, we'll stay as long as, we're at your behest, we'll stay as long as you'd like us to.
All right, I think Alan had a question, and then Karen.
Yeah, it kind of is about your overall rating of the health plan. Don, you said to me one time very eloquently that you know that when the providers are unhappy with how things are going, that your insured consumers are going to be unhappy about 6 months later.
That's right.
Yeah.
I said that exactly right.
Yeah.
Yeah.
How do you measure? How do you monitor the satisfaction of the doctors?
We do physician satisfaction surveys.
Yeah.
We do physician advisory boards, what we call physician advisory boards in communities in Vermont. I try to go to either the first or the last. They tend to be a series of 3 meetings in a community with physicians. So you're absolutely right. If we see physician satisfaction survey dip in any way, we can count on our member satisfaction dipping about 6 months later. So there's, and I think that's, as we go into healthcare reform in Vermont, sort of that causality between the two, between primary care, pediatric medical homes, physicians, and consumers is a really important one.
I agree.
Karen, you spoke eloquently and often about putting members at the center of the Blue Cross Blue Shield Vermont experience. And you spoke about moving from clinical settings to workplace wellness. Just to continue the conversation outside of the structure of employment, how do you think about integrating in the future Blue Cross Blue Shield of Vermont's efforts with public health, that integration piece?
Yeah, a great question. Our original principles for healthcare reform that we crafted in 2008 suggested in them that we needed to have a broad campaign of public healthcare support and consumerism. I think that where public healthcare can contribute is in broad messaging. And by that I mean, this is just one example, by that I mean, as a youth growing up in Vermont, I never wore a bicycle helmet and I never wore a seatbelt. We have demonstrated to ourselves that we can change our behaviors as a people, as a population. When my children grew up and they took off on their bicycles, it was almost autonomic, like breathing. I'd say, wear your bike helmet. Yes, I will. And so we have proven to ourselves we can reinforce those things. And we did those things, I think, through broad public health campaigns, those commercials we saw on TV that we no longer see anymore about wearing bike helmets and putting on your safety belt. So I think that there is a place for that, and I think that's one example of how we may need to spend more and support broad public health campaigns.
Don, can I add to that? I'm not sure if it's on point with your question, but when we prepared the presentation today, we actually had in each of these slides, as you go back to the top block, we had pictures in there, which we elected to take. Well, there's one.
There's one. We missed one.
But we took them out, and what those pictures were predominantly of was public health activities that Blue Cross and Blue Shield is involved in. We have what we call community advisory boards in 4 or 5 parts of the state, which is local kind of decision leaders, generally whoever's the local director of the Department of Health, school superintendents, the town manager, folks who are active in health things. And what they do is they counsel us in fashioning healthcare programs, public healthcare programs, not for our members, but for generally to the needs of their communities. I like to say that I don't know of a single organization in the state of Vermont, there may be one, that's involved, a nonprofit organization that's involved in health improvement, health education, health prevention, et cetera, that Blue Cross and Blue Shield is not somehow a partner with. We actually took all that out of the presentation today because we thought it was the soft side of our business and you really want to know kind of more of the, but I do believe that we're very, very deeply involved in overall health improvement, and that those efforts are not just directed at our members, but in overall health improvement in the state of Vermont.
Maybe you could share those slides that you took out, just send
I
them
would love
along.
to do that.
Be very
Yeah,
interested.
It's robust.
Other questions?
I had a question, when you started talking about the plans, and then the actuarial value, and then the benefit, what model, and this is, you don't have to talk about it if you don't want to, what modeling have you done around that? And, where do you come to on that? And like I said, that may be your own business at this point. But when, there's a Washington Post book that has it does it down to the dollar amount, of what each plan could be in terms of actuarial value based upon, the NHSA plan, in terms of what the person would bear. Have you run any of those numbers, or?
Our actuaries have taken a look at this, and what they've advised us is they do not have enough information yet on the actual benefits. They can give us kind of a rough, mapping of what they think, our current plan, where they go into those metallics, but they can't do it at a very precise level because they just don't have enough information.
So I was just going to say, we'll start delving into this issue on Thursday of this week. And we're going to have several sessions on exchange benefits.
Yep.
So I would hope you guys will show up and pay attention.
We will be there.
We'll need your guidance.
We've been supporting the process with tons of information, as you can imagine, about our products.
When you think about that process, though, and you think of the idea of benchmark plans, what's your initial reaction to that? Is that okay to start with, or are we, with the way the federal government went about that, is that a good starting point, or so we're fine at the beginning and now we'll see where the journey goes? Is that?
Well, if I understand the question, and I'll defer to Catherine too, allowing the states to look at their most popular plans and establish those as the benchmarks, we think was a good thing.
Okay.
I'd say I think that's a practical consideration, since that's where the population, those are the benefits the population has today. I think one of the things you'll see on Thursday is a comparison between MVP and Blue Cross as the two most popular small group plans, and then the state of Vermont employee plan. And you can see that the state of Vermont employee plan has so many additional benefits than the typical small group plan. And so there would be more costs associated with that, would be my observation. So beginning with where the market is today is a practical consideration for you.
Now, how does that relate to what you said about much of the market being below what you're assuming those federal?
Well, it's related, because the most popular plan is now a Blue Cross Blue Shield, TVHP, CDHP. We're great at acronyms. Consumer Directed Health Product, in a $2,500 deductible space. And as you know, the benefit requirements on exchange limit that to $2,000. So the deductible levels will have to come down for that population if you pick that plan.
If you choose that plan, does the deductible level have to come down immediately, or do we get some time to go up to that federal minimum?
From what I've read, I haven't read anything in terms of the transition to that. I've read that the rules are $2,000 is the highest deductible.
So essentially, we'd be choosing a combination of the most popular plan and lower cost sharing.
I think one of the things to recognize about all Blue Cross Blue Shield of Vermont products except FEP, which I know has already been taken, the federal employee program has been taken off the table, is that the benefits, so the essential benefits that are covered in all of our products are consistent across all our products. The variation really comes in play in terms of the cost sharing. So what does the consumer pay out of pocket, both in terms of a deductible and a copay? That's where the variation comes in, and that really will, in terms of the product design, that will define your metallic level, whereas the essential health benefits are consistent.
The theory here sounds like the more comprehensive, to a limit, a plan is, the healthier the population over time, and therefore the cost less over time. Have we reached, has the science reached the point where we can begin to model that level of thinking? Because so far, this whole discussion is in the plan today, what it's going to cost today in today's budget. But how do we begin to turn that into a longer term conversation? It's a rhetorical question.
Yeah.
You mean whether broader coverage pays off in health over time?
Exactly. You're shaking your head. Does that mean you
Well,
would agree with that?
It's a great question. It's worth noting, though, that even the high deductible plans provide upfront coverage for preventive stuff, et cetera, the types of things that you want to improve the health of the population. There's not as many obstacles as you might think just because it's a high deductible. A lot of that preventive stuff is exempted from the deductible, et cetera. So just offering the comprehensive benefits alone is not going to get people having more mammogram, more of the diagnostic screenings and things like that.
Now, how do you know that?
Because I say the benefits already provide that.
Okay.
In the
So
high
they
deductible,
exempt from the
right.
cost
They're
sharing,
exempted from the
preventive
cost
care,
sharing.
Okay.
which is
One of
pretty
the-
common these days.
One of the lenses to consider as you think about essential benefits is, and product design, is the balance between consumer protection and affordability for the consumer and for businesses. And frankly, for the economy of Vermont and its small businesses. So,
I think you do raise a good question that we should all begin to ponder, and that is how much are we going to begin with what costs are today to factor into what the cost of care is going to be and the cost of the benefit designs that are going to be, and versus how much are we going to begin to factor in the pilots that we're doing, the changes we're making into what the cost of care is going to be more immediately. Richard is here, and I know Anya will remember from the pilot that we're involved in together with Fletcher Allen. I have said that I'm more than happy to commit Blue Cross Blue Shield actuaries to helping to figure out a trend for a 3-year global pilot for 40,000 of our members. But I'd also like to factor in care efficiency, care delivery changes that are stated goals of that pilot, and to do that more proactively rather than waiting a couple years to see what the outcome is and then underwriting them into the future. So I think that the cost containment aspect of healthcare reform is long-term enough without or at least grappling with the issue of when do we begin to be confident enough in the things we're doing to begin including them in our future rates.
That's really helpful.
Any other questions or comments?
Just a general one about the benefit. The critics that you hear will say that the benefit that's going to be in the exchange will be worse than the benefit you have today. So your take on that is that it's going to be the exact same benefit if you're with Blue Cross. If it was similar, that it's not going to be worse, or is your take that it would be worse and the criticism is correct?
I think there's a lot of fear around the exchange, and we all fear the unknown, and this is very new for all of us. I think in other markets outside of Vermont, there's significant concern that the exchange is going to attract an unhealthy population because the market rules that have been in place in Vermont for years will disrupt it, and it will create a rate shock for consumers on the exchange or for businesses on the exchange. I think early on in our planning around the exchange, we assumed that the work that Vermont has done, back to in 1992 to have community rating and guarantee issue in place, will mean that Vermont will be much less disrupted when we have an exchange, because we already have those market protections in place, those market reforms. But I think part of it is driving that, and when you read in the national press, that's what the concern is.
Each individual, I think, the reality is each individual will judge for themselves what the change has been for them. And some will find that by going into the exchange, they'll be delighted to see that their benefit design may actually be a bit more favorable. And some will find that their benefit design is providing less as they go into the exchange. I think that's the reality of what we're all going to have to work with.
So I just had one comment. one of our big challenges is to sort of put together the moving parts in terms of healthcare costs and start to have them relate to each other more. So hospital budgets, insurer rate increases across the entire market.
Provider compensation.
Provider compensation. When we, when we tweak one thing, how is it affecting other parts, and what's the overall impact on the system? And we'll, I think, start to get into this soon with board discussions about what is a global budget and how do we start to think about an overall budget. But I think you folks could be particularly helpful to us in helping to, just like seeing that average rate across all of your lines of business is helpful, because that's not something that we will likely see in an individual rate increase request. Likewise, understanding how you might think through if we limit hospital budget increases, how does that trickle out through your costs? What does that do to your cost structure? Would be very helpful. So hope that that's a way in which we can call on you in the future, and you might want to assign your best and brightest to help us out with that.
But we can do that. Said another way, we've been pushing down on the balloon and watching where it pops up in other places for 2 decades now. So I would agree with where you're going, and we're happy to commit some people and time to that with you.
And when there are savings in the system, what percentage that goes to the provider, back to the payer, and how we define that ratio?
I agree with that. By the same token, I always like to reinforce whenever I can, we don't view it as going back to the payer. We view it as going back to our consumers. We need to get this back to our small businesses and our pay, so we need to keep the 0.7% Kevin put up there just to our mandated reserves.
Sure.
Otherwise, that's the relief we're trying to provide. And I would agree, we've got to figure out what that percentage is in the early stages particularly.
Just because this is Green Mountain Care Board public meeting, we are charged with reviewing and approving the exchange benefits. But moving ahead to Green Mountain Care Ultimate, we are obviously interested in what ways does the exchange align or, in a sense, divert us from thinking about Green Mountain Care after that. So that's sort of a separate conversation, but one that we certainly are trying to keep in mind as we focus on the exchanges. How is the exchange a stepping stone to Green Mountain Care ultimately? And how should we think about benefits in that larger and future context? So some of our future public meetings will address that, and we'd be very interested in what ways do you see the exchange aligning or diverting from Green Mountain Care future.
Okay.
Yeah.
I just want to say I appreciate your tone today, and you've committed a couple of times to doing some things with your people and your resources, and I realize that that's not a small thing to commit to, so I want to thank you.
You're welcome. We look forward to it. Pleasure. Travel safely.
I hope not to call you.
Yes, exactly.
All right, any other comments or questions from board
For a week and a
members?
half, then I'm going to call you a lot.
Any comments or questions from the audience? Marv?
I have 2 questions, both of them center around evaluation programs. First program I wanted to ask about are your, say, the wellness program or the care management program you spoke of. Speaking of somebody who worked in primary care for many years, the care management programs put up by Blue Cross was often redundant with what the state had us doing in the blueprint. In Barrie, we were one of the first practices that entered the blueprint. Patients were often a little afraid of the insurance company. They thought their care might not be covered if they didn't cooperate and take these phone calls they were getting from Virginia and Tennessee. And then another issue is, of course, people, and I'm an employee of Central Vermont Hospital. We've switched healthcare plans back and forth from MVP to Blue Cross. I think one year we even at Cigna. Just every year, literally every year we've switched. And obviously then our care management plan would switch. So my question is, now you're saying that you're thinking of dropping out of care management. Thank you for that. But my question really is, has there ever been an evaluation? You're spending millions of dollars. Over the last 10 years, you've probably spent millions of dollars in this program. that's part of that 8 cents out of every dollar that goes into Blue Cross that's never seen again. And I guess the question is, are these programs evaluated? Is there a suitable control group? Part of the state could get the program, and another part could not get the program. In the wellness program, another example, maybe the people who are going to start exercising were contemplating exercising anyway. They were about to do that. So do we ever get an evaluation of a program that's going to eat up millions of dollars? The second thing I'm asking about an evaluation on are high deductible plans. And there would be 3 areas of potential savings. One is you're saving money because the patient's spending the first $2,500. But maybe there's also less utilization. And my experience in primary care, now I now work as a hospitalist. And my experience as a hospitalist is that they don't matter. We just do what we got to do to get the patient through the hospitalization. However, in primary care, it felt the impact of high deductible plans was big and extremely annoying. People didn't want to come back for blood pressure checks. They didn't want to get their potassium level checked after I started hydrochlorothiazide. You know, I mean, it was nickel and diming me, and primary care is hard enough anyway.
Mm-hmm.
So the question is, have you evaluated high deductible plans compared to other non-high deductible type plans to see what types of utilization? Maybe all we're picking at and all you're suppressing are primary care visits or preventive care visits, and I'd love to know more about that. So those are my questions.
There's a lot in there, all very good observations. One of them seemed to be about the care management programs we have today. They do cost money. They're charged, our customers are charged a rate for them. I can tell you that for the last decade plus, every year at Blue Cross of Vermont, they go through a very rigorous review. One, are they saving money for the customers who are paying for them? Are they contributing to quality? And what is the impact they're having on the member experience? And all 3 of those things have to reasonably fall into place, and it absolutely does have to save money. Now, if they save money, it would beg the question, why are we open to having these integrated with providers in a different way or turning them over to providers? And I think it is because the programs where they are saving money are not optimal in terms of a future delivery system in the state of Vermont that we're all working towards. So the programs do save money, but certainly not at the rate or in the optimal way for physicians and patients. So
are those evaluations in the public domain, or is that private?
They're not in the public domain. They're at Blue Cross Blue Shield of Vermont. But if you wanted to meet with us, this is anything. We share it with our customers. We shared it with community leaders before. We shared a couple of them today about end of life and better beginnings. So as an organization, because we're not subject to public meeting laws, does not in any way mean that we aren't an open book and aren't willing to share what our outcomes are and what our management process. We absolutely are.
I've been wanting to ask you that question for years. Is there ever an evaluation of these programs? Because it never felt like these calls from Tennessee and Virginia were pretty much useless.
Right. We've dropped programs when they have not been shown to be contributing to cost management quality and to a favorable. When they're creating an unfavorable member experience and they're not saving much money, we dropped the programs. We changed the programs. The other question you have about is our evaluation of high deductible versus lower deductible plans. I tell you, generally our actuaries would say that there's a savings effect that goes along that is relatively predictable with a high deductible plan. I would say that its impact on care delivery, we haven't either have not seen or really haven't analyzed in a way that we would need to make the sort of judgments that you're speaking about. I think it is an interesting issue, and it's one that we should pay attention to.
Okay, other comments? Thomas?
Quick one. What mechanism are you developing to fully fund evidence-based primary prevention? Meaning those procedures and services that actually prevent the birth of a disease. Mm-hmm. And when people don't get disease, it doesn't cost as much. Mm-hmm. And when I mean evidence-based, I mean those that are actually improve health mm-hmm. and reduce medical expenses. Right. And there is a lot of evidence that these exist outside of the conventional medical system now. Mm-hmm. So,
well, my answer to your question is this, and you let me know if it's responsive. There are health plans that are developing benefit plan programs, and they're called, I believe, smart benefit programs. I mean, they are only going to pay for care that is delivered evidence-based. My own view on this is I think that we should endeavor to get there, but I don't think that there is enough consistency in the delivery of evidence-based medicine to say that we're not going to pay for that care. And I'm not sure that as a health plan we're in a position to make that judgment, nor do I think you'd want us making that judgment today. I think that providers ought to decide what is evidence-based care and what is the optimal treatment. And I think we could even define that in Vermont. But we're not looking to live in that space where we would create benefit products in which we would only pay for evidence-based care. Although that is in our principles for healthcare reform, we think that care ought to be consistent with evidence-based models of the best available research.
Any other questions or comments? Deb?
Yes, my question is, I used to be in primary care also, and the practice I was in it was a private practice with 5 physicians, 2 nurse practitioners, and my understanding was that the reimbursement for services was different for private practices than it was for hospital-based practices, or hospital-owned practices, and that we in fact didn't get an increase for 10 years from Blue Cross for, I believe it was for a physical, and it took the person who was managing the office to call Blue Cross to ask why this was happening. And my understanding from another private practice practitioner physician had the similar problem and found that apparently hospital-owned practices were getting reimbursed for the same service at a higher rate. So that was question number 1. And my second one, do you ever measure your impact on the administrative costs within doctors' offices and hospital offices as far as administrative? The things that you create in terms of like some of the hoops that you make us jump through, has that ever been? Because there are national studies that basically show that something like it's $50,000 per provider, and not just your company, but all payers, including Medicare and Medicaid.
Right.
I was just wondering.
We have our physician fee schedule is, we look at it every year. It is common among community-based providers in Vermont. That means for community-based hospital providers, it is still the same. It is, although it is not universally known, it is generally understood that we have a negotiated different fee schedule for physician services with Dartmouth-Hitchcock Medical Center and Fletcher Allen Healthcare. And depending on the specialty within primary care and subspecialties, the fees can be different, and the fees can indeed be higher to support the tertiary teaching aspect of what those institutions do. So when you say that hospital-based physicians are paid higher by Blue Cross Blue Shield of Vermont, that can certainly be a true statement when it comes to the tertiary teaching facilities that we have contracts with. The other question that you...
But these were primary care offices owned by a tertiary care hospital.
Right.
But the point is that it was primary care. Primary care delivered owned by hospital-owned practice versus primary care delivered by a private practice.
Right.
And the cost was the reimbursement was much lower.
Right. And if it wasn't clear in the first time I said it, including primary care, in those physician fee schedules at Dartmouth-Hitchcock and Fletcher Allen, you will find higher fees than we pay to our community providers in the state of Vermont.
And I think this is one of the issues that you'll see us have to delve into as we look at how to come to something more like equal payment across providers and across payers. There's a lot of complexity there, and there are reasons why there are differentials in some cases, and in some cases, and there's a justification in some cases, and I think in some cases it's just more random variation. But as we get into the data, we're definitely seeing that there is tremendous variation across payers and tremendous variation across providers.
And it's just not with physicians. I mean, it's all kinds of hospital procedures. Hospital. I've been going through some of the schedules, and it's quite remarkable, the differences. Mike? Or who said
I
it?
just got a question. I'm not even sure who answered this, but will the adoption of the ICD-10 drive us yet further away from a true common claims form? And secondly, how will it affect, or will research being done now on an existing claim system lose that validation, or we'll be able to continue doing those kind of research with a change to ICD-10?
Who invited
do we know?
Mike?
Thanks, Mike.
Sounds like a good final project.
You know, the things that you said about ICD-10, and I'm not an ICD-10 expert, but what I've heard, it was actually news to me, so thank you, Georgia, about that we're not aligned with European countries in exchange of information, but that ICD-10 is going to allow us to be much more detailed in quality measures and data analytics. That information is going to be able to be used to improve quality and clinical care delivery. Is the simple reasons that have been offered in literature and in consultants I've heard speak to why we're going from the complexity of what is 10,000 codes today to 70,000 codes.
There is an issue of continuity though, because the codes, as I understand it, this is according to Norm Ward, the codes don't necessarily roll up into the old categories. So if you're looking at analysis at point in time prior to ICD-10 and post ICD-10, there may be a problem of matching up. Peggy.
I'd just like to comment on tertiary care centers providing training in Vermont. I don't know the situation in New Hampshire, but every practice in Vermont is used for medical student training, and residents are used in a fair number of those, whether they're associated with being hospital-owned or not. Okay. And so I think that's a consideration in terms of this, what I consider unfair compensation at Dr. River.
I certainly would agree, and it's a good conversation. I think what Anya said is correct, and that is the reimbursements that exist today are 2 decades long, and I think can and should be reevaluated as to how they fit into fair and equitable reimbursements in a reform system in Vermont. Also, I recognize you had a second part to your question, which was about the work we've done with primary care providers, and I have seen Dr. Shao's report. I think quoted $40,000 is the savings through eliminating duplication. I can tell you I attended all sessions of a physician advisory board we did in Brattleboro. It was on this very topic. It was on how can we work better and eliminate duplication and reduce unnecessary paperwork in your offices, and we came to some conclusions that we did throughout the state. That's not to say that there are not things being done today that are creating paperwork or duplication within physician offices. And the commitment we make here today is you see that part of our future plan would be to work with physicians in a reform system to eliminate that duplication. I would acknowledge that in some ways, hopefully it would be less for Blue Cross of Vermont in terms of some of the work we've done, but I would say it does exist, and that part of our future plans and our commitment is to see how we can eliminate those so that we're not duplicating efforts.
You mean like single payer?
I think that single payer, I don't think we need to wait. We're available. We've worked on these things outside of having the supportive structure of a government apparatus like the Green Mountain Care Board. So I think that all of these things should commence. We have 3 payers in Vermont. Blue Cross covers 73% of members. So I'd like to think our commitment could get us 73% of the way there, and we're committed.
Walter.
I've been a patient that has actually had to fight Blue Cross Blue Shield, not once, not twice, but several times. The first time was in '03, and I had 2 operations, the pleasure of a colonoscopy and then a bladder removal. And the copay was $50 for the bladder removal. The colonoscopy came later. Blue Cross Blue Shield jumped my copays by $200. And they never told me, they just went and did it. First question is, what's the justification for that? Second question is how do you handle, my second problem was also with Catamount, is I had to battle Blue Cross for Catamount payments. And it took a long time. I actually lost the fight, and I wound up having to pay like $400 myself, which is typical for people. My questions right now are, how do you justify co-payments, and how do you justify high deductible plans, and why a grievance procedure is so complicated?
2 things.
I've been through them, so I know what they're like.
At the time that your copay was increased, were you through an employment situation or through?
I was employed at the time. Blue Cross Blue Shield said, well, our expenses have increased. And I said, well, my wages didn't increase to cover your expenses. The answer was tough luck.
Well, here's a couple of things. One is, I'm uncertain, other than perhaps the benefit design you were purchasing through your employer at renewal, they chose to change, and that could increase your cost co-insurance, it can increase your deductible, your co-payment.
They were not changed.
Circumstances like yours are ones that we are more than willing to and actually appreciate the opportunity to dig into. The only one position I've hired in 3 years, added new to Blue Cross Blue Shield of Vermont, has been a member ombudsman who works full-time with me on any kind of member issues of the sort that you related to us, so that we have one person who works with you and who digs into them, not only to get you the answer that you need, to make changes in our company if we feel that's appropriate. I just sent a letter back to a member the other day thanking her for bringing a series of issues to our attention and relating to her changes that we've made within the company. As Kevin said, we'd like to think we don't drop the ball too much, but we drop the ball on occasion. And we try to learn from it, we try to make changes, try to make sure that another person doesn't have an unfavorable experience. So we're more than happy to spend some time either here today, or I'll give you my card, you could call us, and we would look into all of this and get you the answers you need that I just can't provide you in the auditorium today.
The claims are kind of old. I was just, they were old and it's difficult, and I was just more concerned how it's justified, and also to follow up on what Marvin says, how are high deductible plans justified? I've been under those too, and they're not fun for a patient.
Yeah, the high deductible plans are what drove us, in part, in 2009 to be advocates for comprehensive health system reform. We're not pushing high deductible plans, and our customers who buy them don't want to be on high deductible plans. It's the only choice they have in order to be able to keep their health insurance given the cost increases that we've experienced over the past decade. So I think that's a lament that we can all share. And one of the reasons why we're saying we're committed to working with government and to reining in the cost of health care and to projecting ourselves as an organization to change if need be in order to make that happen.
I was going to say, perhaps in closing, Walter, I think that your comments really remind us of keeping our eye on the ball. That you said, the expenses increased, but your wages didn't increase, and therein lies the problem that we're all grappling with. There was an article in Health Affairs a couple months back that said basically, over the last decade, Americans lost all real wage increases to health care.
Yeah, I read the same article as well. They've lost real wages because of that.
And people are doing things, they're buying cheaper insurance essentially in order to cope with that, but that doesn't really solve the problem.
This doesn't, no, I can tell you what it's like.
Thank you all. Thank you, Don.
Thank you very much. Thank you all.